Steve contacted me because he said he's had some experiences where he works with the handling of the COVID-19 situation. And so he wanted to go on the record and describe some things from his workplace. And so if I could just start off, Steve, and get a little bit of background, which you started to tell me about where you work and things, your experience.
Yeah, I'm a respiratory care practitioner. I work in an urgent care, ER, ICU, intensive care unit setting with, what they call intensivists, pulmonologists, cardiologists. So we kind of collaborate. I mean, we're told what to do basically, but we can question and, kind of, give our own ideas, so to speak. Our profession is kind of a newer profession. I don't think in Great Britain you have that. I don't think you might have pulmonary nurses but we have it's called a specialty, basically.
Right. Yeah, I'm not sure we do have those. Not with probably have slightly different names. If we do have them, we may find they only have such staff in big cities or places like that. So you've been working in that kind of role for, I think you've mentioned, like over 20 years, and you work in a couple of different establishments where you have worked.
Right. Yeah, and I'm what I do is I work what they call per diem now, and I have been since June 1st. But up until then, I've been working at both facilities, maybe half time. And it was interesting because I have time to actually look at literature in my job, because the main job where I was working, I'm the only respiratory therapist there, or respiratory care practitioner there. So they kind of rely on me, the doctors and the physician assistants, they'll give me an order, but then, they'll definitely take my input. So it's because they're not quite sure about my level of expertise. And then plus the equipment, we have a whole room of different types of devices, that we use, and they no way they could know all that. So they have us there to kind of manage that. If somebody comes in, and it's primarily people with trauma, people with chronic lung disease, children. That's really the thing I've learned. I've been there about 8 years at this urgent care setting, and I haven't worked with a lot of children, so I'm learning that. I mean, I've really become good at that, working with pediatrics. And I work with a pediatrician half the day. They come in for half the day. So we have all these different devices, and initially we were told to use to basically, once we triaged, we were given a lot of information from China, from the CDC, the World Health Organization, about what this was. They seemed like they knew everything about it. They said it was like a 3% death rate, and that maybe the best thing to do would be to pre-intubate, they said. So that means if you saw those signs and symptoms, to go ahead and pre-intubate. And so we were following that. That's what we were doing initially.
So this was the guidance you were given early on then. Sort of what's the time frame? You're talking sort of April time, March time? What sort of time were you getting that?
We were getting this, I think, probably in February.
As early as that?
Yeah, I mean, we had actually turned our whole urgent care around for triage, and we had an incredible system set up. We had a remote triage area, meaning no one came even into the urgent care before they were screened with the any kind of respiratory symptom, because we didn't have, back then we only given like a dozen PCR tests a day. That's all we could, so we we only used them on the real serious patients, and that was really causing the stress. Is everybody was coming in wanting a test, but they weren't sick. And so
presumably that when was that test sort of started to be used? That must have been surely a bit later.
That was probably end of January, beginning of February, I think. That's when we first started getting those. But going back to December, I remember reading in the literature, that there was this thing that was pretty bad, and I was showing it to my director, and I was starting to post stuff up in our board, for everyone, staff to look at. And then I think it was like in January, I think it was the end of December is when, I mean, all this information started coming out, and they said, we know what it is. It's deadly, watch out for it. It was like, I think it was like December 31st is when we got like the confirming stuff right from the scientists from China. And so I think the first and second week in January, we were getting recommendations. I think I printed out a draft first or second week of January, and I said, whoa. And it told us, yeah, you got to change everything around. This is probably going to be a pandemic, you know.
And do you have any of those documents available? You know, so, I mean, you mentioned in your
Oh,
email that
yeah.
you know, some of it was confidential and stuff because of patient confidentiality. But if there's anything that you could send me,
I've got
okay,
tons of stuff here,
wow.
recommendations.
And this is all sort of from January, February time, early March, maybe that sort of time. Was it you were getting those sort of documents, you know,
Well, this one,
coming into your radar?
this one's October because we've kind of changed how we treat them now. But yeah, I've got just I got a big futon here, and it's covered with
Wow.
all the stuff, even like the Department of Health results, you know, by week
Yeah.
18. I mean, I've got just all kinds of stuff. I've got like X-rays, and you know, these are publicly,
Well,
no one
yeah.
knows who it is, so this is just
Right. So that's just
something
from, yeah.
to look
Oh,
out for.
okay.
This is
Yeah,
what
because I mean, I mean, you'd look at those, wouldn't you, depending on what, you know, to look at, to sort of manage the condition
yeah.
or check the diagnosis and stuff. So, I mean, your expertise would maybe to look at X-rays like that, and then look at sort of treatment for that condition, and you know,
And
perhaps you were
yeah,
looking
we
at
were
things like
actually,
ventilation or supply of oxygen, or you know,
yeah.
do you use things like CPAP? I mean, I know a little bit
Okay.
about respiratory because my wife, she was a pediatric intensive care nurse, so she was involved in ventilating children, intubating them. So is that something you would do? Just you intubate them, or would some you would recommend that and somebody else do it?
Yeah, so it would be, you know, if there was a you know, if the doctor wasn't sure, a lot of times we collaborate, and I'd either say no or yes. And I've got my own rules that I kind of know if the, you know, if they're beyond, if they've been, you know, having trouble breathing for more than I think 3 days, if I find that out, then I usually don't try the CPAP. I usually tell the doctor, yeah, we probably should just intubate this patient because they've run out of energy, you know. And the CPAP is driven more by the patient rather than
Right.
mechanically. So yeah, there's certain situations where it would come up, but the doctor always usually directs things that we do. But what's interesting is, you know, we were getting these recommendations and we were following them, but yet we weren't having great outcomes. I mean, you know, we had a lot of people pass away I think it was in March was the worst month, I think, around here. But I guess I should explain too that we usually don't get the flu or cold season out here because for some reason it always moves east to west, at least the one they make the vaccines for. We don't really get it till earliest is like end of January. Whereas like on the East Coast, it's like November, you know, it's earlier. So we kind of we lag behind the rest of the country when we start seeing patients come in. But I guess with the COVID, we actually had I think one of the first COVID cases. We had I guess it was the Chinese New Year celebration going on, and this gentleman, a middle-aged gentleman, came back. Ended up not at our hospital, but at one closer to where I live, actually. And I know the director of that respiratory care department, and but he was in and out in 4 days. It was more of a moderate. I don't think maybe he was on the ventilator because they were just putting everybody on ventilators back then. They suspected COVID, and part of it I think had to do with to protect the environment. You know, the other patients. You know, it was strange, but then we quickly found out that oh wow, this is not because what we do is we usually put the patient on the ventilator, and then within 30 minutes to an hour we draw what we call an arterial blood gas to find out, you know, if we're, you know, to change settings or to adjust or to give medicine or, you know, or even to extubate, to take the patient off the ventilator. And so we were getting immediate results back showing, or at least in the hospital. I mean, I don't think I drew any ABGs on any of these patients, you know, which is odd because that's the first thing you're supposed to do. If a patient comes in and is having trouble breathing, you just draw an arterial blood gas to see what's going on. And I think if we would have done that first, instead of putting them on the ventilator, we would have avoided a lot of the problems initially.
Wow. I mean,
Because what we were, Yeah.
I'd
Well,
heard that, there's this, I think I mentioned in the email that there was this doctor that came out in New York. I can't remember his name, a youngish chap, and you may have seen the video. He had a blue, smock on, and he was in his kitchen or something. And he said that they got some patients in, and I think this telling a similar story to yourself. And they changed the protocols for dealing with these patients, and then I think one or two of them had died, and he'd become very concerned about that because he knew that that shouldn't have happened with those sorts of symptoms in a number of cases. But what he described was, and I said this in the email, was that and I'll say, when I first saw this video, I thought it might be disinformation, but over time I probably changed that assessment. And he said he was seeing what he thought was symptoms of altitude sickness. It was more when he'd actually reflected on this and looked at the symptoms of these patients, and I think he'd seen the X-rays of the lungs as well, and seen the damage in the lungs from whatever it was. He thought, well, this looks like altitude sickness. I don't know how that ties up with what you experienced, or what your thoughts on what this doctor said about these patients. I mean, what are
yeah.
your thoughts on that?
Yeah, it's not, well, you do get fluid in the lungs with altitude sickness, but I mean, this is not altitude sickness.
Okay.
This type of X-ray, it's not. It's scary when you see that. That's what a condition would be called acute respiratory distress syndrome. That means they should have been on a ventilator yesterday.
I see.
It should have been.
Yeah.
It's almost like, uh-oh, we're going to lose this one kind of thing when we see that X-ray. So, basically, there were combinations later during this 3 or 4 month period. We were seeing even stranger cases, which I'll go into a little later, but initially it was this violent kind of I can't breathe and I'm dying kind of scenario, and with the what we call ARDS looking X-rays. And so of course we just knee jerk kind of let's intubate and get them over to the hospital, where they can be watched and adjusted and stuff. But then we started, the patients were not doing well on the ventilators. They they're just dying no matter what we did. But like I said, a lot of the results were coming back that this wasn't a ventilation problem. It was an oxygenation problem. So it was almost like they had these massive blood clot, but they didn't have like what we call, a pulmonary emboli or anything. And that's what was making everybody confused. We were trying to figure out what is this? What kind of condition is this? This is very strange.
So is it characterized then by having low blood oxygen? There was not enough oxygen in the blood. Was that one of the symptoms?
Yeah, that was the thing that really clued the intensivist to kind of change the type of reaction that we're having, because we were kind of more emotional about it and just, doing what the recommendations were without really taking seriously the.
I suppose there was kind of like an underlying assumption that the information you were being given was accurate, and this was some kind of weird illness, which
right. It could have been this patient could have just been an anomaly, but then it started seeing more of them like that, and that's.
And when you say these patients were, were they all age ranges? Were they male and female mixture, or was there any particular type of patient that was more seriously affected? Were they all elderly, for example?
It was kind of younger. It was like in probably the 40s, maybe late 30s, and then up to late 40s, I think, is what I noticed. And when I talked to because I wasn't really, I was kind of scared too. I was like the only RT in this urgent care, and I asked, the director, I said, are we gonna have more respiratory therapists? And she goes, no. And I was like, oh my gosh, it's gonna be crazy. But then we didn't, there wasn't anybody coming in. And of course, people were afraid to come in the hospital, but it was just like these every now and then we get them coming through the urgent care. I think most of them, people would just call from their home. The ambulance would come pick them up, take them right to the hospital. We weren't even like, and most of the people that were coming in were people with anxiety over the whole thing. And we just had to screen those patients out and just send them home. They never even came in the urgent care. We had like a remote screening in a separate room with a doctor or a PA at home, and the patient would come in. They were instructed by the nurse to go in and press the iPad. We had like a little iPad there, and the doctor would come up on the screen like I'm talking to you on Skype, and they would go through an algorithm of questions, and 90% of those, they just say, you don't need our service, go home, you know. Or if they had sniffles or something, they had a choice if they wanted to come in to get a PCR, you know. But most of them, I think, were coming out negative back then, the ones that were doing, you know, because it was too early on, I think. And again, I mean, we had a bunch of stuff going on. It wasn't just COVID. There was like this very strange, and your wife might know about this, because there was this very strange respiratory syncytial virus going around out here. I got it, and this thing, all you need to do is get a whiff of this thing, and you're sick, really sick. It doesn't last long. It lasts like 3 or 4 days. But this is not an adult illness. It's a childhood illness, and for some reason, it became an adult version this year. We've never seen that.
I'd heard a few. There was a couple of people locally that said they got. In fact, there's a lady that lives a couple of houses down from here, and I think her husband, it was the wife of the couple, they got some very bad illness, and they were bedridden for a few days. They're sort of in their 70s, I think, and that was in December. And then my wife's uncle, who's also similar age, sort of mid 70s, they apparently had something that confined them to bed, and they're usually pretty fit and healthy. They were confined to bed. I think that was, before all this COVID nonsense broke out. That was in December as well. So again, it seems like there has been a debilitating illness that's done the rounds, but it doesn't seem to tie up with the COVID description at all. They've somehow become obviously overlapping and confused in the public mindset, and of course that's all part of the fear mongering and stuff. But anyway, carry on.
Yeah, so I think it wasn't until April. I mean, and I was following like the situation report daily from the World Health Organization. It seemed totally logical. I didn't see any misinformation. I'm serious. I mean, it seemed like totally matched with what we were seeing. They even had to come out and say, I think April 3rd, right on the front page of the Situation Room, they had a statement. They said, we have not seen any asymptomatic transmission of coronavirus. They had to put that out there because there was all this information that all you had to do was test positive and you could spread it to everybody. And so it was like, wow, that's amazing. I mean, it's like they're backing up what we're seeing, because it's a droplet transmission. And there's a disinformation that it's this aerosol or airborne disease, kind of like tuberculosis. And it's not. We don't see that. If it was, all of us would be ill in our department because we were treating these people. I mean, we weren't seeing, our numbers went way down through this too in our urgent care, even in the ER at the hospital I work at. All the numbers, it was like less than half of what we'd normally see. It was so quiet. And it was like that all over. It wasn't just in our hospital. Everywhere I checked, I even went into the hospital close to me. It was like crickets. I mean, it was so quiet there.
And so, I mean, basically the picture you're telling me, that echoes what happened in the UK as well from, I haven't direct experience of that, but I've read plenty of accounts online and seen videos of nurses saying the same thing. But so what you're basically saying is the pictures, you had some weird respiratory illness, which got pretty bad with a few sort of deaths, presumably, in sort of March, April, May sort of time, was it? That sort of time, or January, February, March?
Pretty much by the middle of May, it was over. We kept everything up, all the isolation areas stuff, just in case. It's over, and it really hasn't returned. I mean, we're not even doing the remote. I mean, we have had more patients come in. It feels more like a normal type of environment now when you go in, because you have normal people coming in, the normal kind of, mostly we see abdominal issues, people with stomach illness. That's primarily what we see a lot, and now we're seeing the trauma from the ski season. And then you get these people that come in with respiratory illness. And of course, we just want to check them, but most of the time there's nothing. or they'll test positive, but, they don't really need to
Sure.
go in the hospital.
There's no
They
real
can go,
symptoms. Yeah.
they have mild symptoms, and most people that get this are not going to die from it, and that's the thing that worries me, is that when we started really seeing a clear picture, but yet they kept ramping things up.
Mm.
And you're like, well, was something coming that you're not telling us about? Because it's it's pretty much over by middle of May, you know, and then nothing after that, But then they kept reporting, oh no, it's going up, because they were using, like, I saw your on your website about the PCR, how inaccurate using a PCR test. I learned about that from your website. Thank you, because I don't really know all aspects of it. We're just told stuff in the
Yeah.
hospital, and
Yeah. Well,
we
that's right. I
true.
mean, me too. I learned about the PCR technique probably not much time before I put that on my website. Probably, I was learning about it from other videos and postings. But one thing I think we can maybe spend a few minutes talking about is the swine flu situation as well, because you said you'd
Yeah.
had experience of that in your work. So I think you were still working in that sort of respiratory care, or in an area of care which was partly to do with that. I think you said you were working in that area too. So tell
Yeah.
us a bit about your experiences with that, if you've got any.
We were getting positive results along with the positive results for swine flu. We were testing for both the first couple weeks. When was that? February. I think it was It was either through the end of January, beginning of February, or the middle of January. I can't remember exactly, but it was in that, either 4 to 8 week time period where we were testing for both, which you're supposed to,
Oh,
because
okay. Yeah.
February is kind of our month for flu
Yeah.
around here. And so I think after the second or third week, we were told not to test for flu anymore, to just focus on the COVID. And I was like, well,
Ah.
maybe in the East Coast and the Midwest, the flu season's over, but not out here. I mean, we're just ramping up. We're just starting up here. So I thought that was strange, because even though I have to say though that flu test is even not very accurate. I
Yeah.
mean, it isn't. I mean, a lot of times the doctors they stop doing it because they already know the patient's not going to die from it, and they don't need to categorize it. Um, and so when we stopped doing that, and we had more patients. I mean, in March was probably the worst month. End of March, beginning of April was probably the worst time of it, where we saw more of that type of patient. Even then, it was pretty slow, because we weren't. I saw it just was an unusual. That's what it made it feel so unusual, because we just weren't that busy. We were just waiting, and we worked 12-hour shifts. So it's like, this is
Bit of a,
ridiculous.
yeah. Yeah.
We just weren't doing much. So then in April, I think it was like the second week of April, I always look on the CDC for the hospitalizations. That's kind of a benchmark to see, how bad was it. And wow, I was shocked when they said that there was 62,000 deaths in the U.S. alone from the flu. I was shocked, because we stopped checking, and so we don't know if we had flu or not. I mean, I don't know about the hospital, but where we worked at, we weren't checking. The hospital may have kept checking, but
So
that was
this figure of
shocking.
62,000 flu deaths appeared, and from your
Yeah,
experience, that couldn't have been true because you hadn't seen anyone with it, and based on a law of averages or whatever, that would,
yeah,
you would have expected that to be much lower than it was, presumably.
right. And 77% was swine flu. That's what they said. 77%. Now, up until, because I kind of we get. I have an association, so I got access to all these periodicals. I don't have to pay for them. I can just, go on my association website, and they were showing like a 44% efficacy with the flu vaccine, right? Up until kind of the COVID thing hit, and then it dropped significantly. I think it was, pretty much what we see every year is about 10%, 15% that the flu vaccine works. This year was no different, but there was just a lot more people with the flu. And I think worldwide, they said 1 billion people had the flu. Now, I don't know. I mean, I've read articles that say that viruses work together. In fact, I know viruses, are prelude to a bacterial problem, bacterial infection. I know that for a fact. But that viruses actually work together. So could this have been a combination, you know, of a thing that was more like a swine flu? Maybe we had a more of a swine flu issue. And what I thought was also interesting, in July, the CDC updated the flu and they changed it. They changed all the stuff, the benchmarks that they put out in April, and they said, well, we're thinking more it's 22 to 62,000. There's like a range of people that probably died from the flu. So that tells me that maybe they're confused about either that, or they're either putting out disinformation, or they're confused about who had the flu and who had COVID. I don't know.
Yeah. Yeah, I mean, the stories don't add up, do they? I mean, that's the thing. And
Yeah.
the other thing I might ask you is, do you have any experience of, the way that the deaths were classified and counted and the death certificates were written out? Did you get any of your staff said, oh, normally when this person died, we would have filled in a death certificate, and
Well,
they changed the procedures? Did you become aware of anything like that going on?
no, I wasn't working directly in like the ICU or I was
Okay,
working in the ER over in the hospital during that time frame, but no, I didn't.
you didn't really.
Everything's electronic charting. I don't know how anybody could really, you know, cipher that out. Because we used to have paper charts. I mean, I guess you could go on and look at what the doctor wrote,
Mm,
what they documented the cause of death, but in our department, we didn't see anybody die. In fact, I think I brought over the first COVID suspected case to the hospital. Because I guess I should explain. I work for a different hospital organization. I have one hat for that one, and then I also work for a community-based, donation-based, very well-funded hospital. And the very well-funded, community-based one I've had most of my experience in. The for-profit kind of uh, place I work at, I'm just kind of like in an ER setting. And when the patients come in, I can make recommendations like they should probably go to the hospital, or no, they don't need to go to the hospital. And so it's almost like we're not really a delegated screening process, but we have to make our case to send them over there into the hospital. There's a little haranguing on that because there's limited even before COVID, there's limited beds and stuff, but that's a whole other issue.
yeah.
But so I'm in this really unique situation where I can talk to my colleagues and my at the hospital, and so I can uh, find out, and I actually got in arguments with a lot of my coworkers in the hospital because they were saying, "Man, you're crazy. This thing is just the worst ever. It's the worst thing ever." But later, I think they're rethinking that because they knew, now they know we were treating the patients wrong. So we were actually causing more problems to the patients than the COVID was if they had COVID. Uh, so
But
it's yeah,
you still don't know really what they had, do you? Would that be fair to
yeah.
say that whatever was causing the issues is still a bit of a mystery? Because
It's,
it wasn't a particularly a flu-like illness, but whatever it was, the treatment that you gave them wasn't really
well,
giving them any help.
I mean, we were trying on more of the moderate cases with a new type of therapy, more of an oxygenation therapy that had, it's been being developed for the last 15 years, called high flow nasal cannula. And initially didn't have much success with it, but when we tweaked it, we had great success with it. And that's pretty much what we do initially now is we use this high flow nasal cannula system. But yeah, that's the learning process, in the
Yeah,
ICU.
I'd heard a similar account, I think, from something else I'd read, that it basically just a use of oxygen. So you were oxygenating the patients, albeit using a particular technique, but that was
Yeah,
more effective than ventilation. Is that my understanding correct there?
yeah. And it had to do a combination with fatigue and muscle fatigue
Ah, yes.
and low oxygenation. So and I think that's what they're splicing out now is there's theories that that this it may enter through the respiratory system,
Mm.
but initially it doesn't affect the respiratory system at all. It's almost like your respiratory system is like a hypodermic needle to get it into the bloodstream. And in some of the COVID, not all of them, there's a micro subset
Yeah.
group. Those are the ones that come in like, whoa, they're really bad. So it starts in the bloodstream and then it eventually works its way out back into the respiratory system. Where initially we thought, which makes, in all other viral type of respiratory viruses, yeah, you ingest it and it just totally destroys your lungs. But in this one, it's like it actually gets into the respiratory system without affecting it, and then it builds in the bloodstream, and then you start to see
Mm.
the respiratory problems.
Mm. Mm.
And this could happen over a period of 1 to 3 days, maybe. That's what normally see. And I should add that the patients that I saw that came in with none of the normal symptoms, but yet had low oxygen saturation and the what we call the ARDS or uh, cytokine storm looking X-rays, had been traveling.
Mm.
Like the first case, I think this gal was in her mid 40s, no history of lung problems, not a smoker, no COPD, no diabetes, no issues, right? And she was just, we said, we got to get her in the hospital right away. She's bad, but yet she's no fever. You know, that's the thing that's weird about it is some of these patients, they don't have the normal symptoms. And yeah, and then, yeah, the other two, the same thing. They've been traveling,
So it's almost
couple of-
like they picked up some kind of something which was actually, if I can oversimplify it, somehow it was targeting their, the muscles in their lungs or something. So it was that was stopping them from breathing, kind of, or you say it was making them tired, or that was, maybe I'm putting words in your mouth, but you said that some of the other patients were getting tired. And it's almost like whatever got into their body was making the lungs not work very well, maybe
right.
because the muscles were tired or something, and that's what was causing the oxygen shortage. Perhaps
Yeah.
is an
It's
accurate.
almost like there's this it's almost like the virus acts like a drug. Seriously. I mean, the latest theory, they call it the bradykinin storm, what occurs in the bloodstream, the circulatory system. So basically, bradykinin is like a precursor for, your clotting factors. And so that was really weird when I read that new theory. I mean, it's not proven, but how can a virus, it basically is changing. I mean, I can see how it's basically your body not reacting normally, for sure, right? To something that's an infection process. It's just not, it's like it's haywire. Your immune response is totally haywire. It's like it's trying to fix a cut when it should be, going after and it's like the wrong
Response.
response. It's the wrong response almost, your body's
Mm.
given.
Mm.
And I think they said it was most of the people they've discovered that have this kind of response are they have a rare form of type A blood type. Have you heard about this?
I think I did vaguely hear. So you found that there was some commonality with the blood type among the people that were affected then, most.
I don't know about the patients that I saw when they came in the urgent care, what their
Okay.
blood type was, but
Oh, okay.
I don't know about that. I didn't look at their lab records. See, I don't even think they list their blood type in their lab records.
Okay.
I don't know. That's kind of kept some of the times when you go into the charting now, there's confidentiality issues, and
Yes.
unless you have a reason, you know,
I need to
for
know what
that information, you can't get into that. They have a very, very closed system. And it's to protect privacy,
Yeah.
and yeah, I think that's a good system to have.
Yeah.
I wouldn't want people to know, you know, everything about my labs and blood
Sure.
tests and even
Sure.
clinicians, unless you really need to. A lot of times I'm allowed in, I can override. If it's an emergency situation, I can get into all the data and information. But most of the time I'm not interested anyway. I don't really care about that. I just want to make the patient feel better,
Sure.
and that's kind of my goal. I'm good at that. I think I'm really good at that. I seem to be I've been around long enough, I think, you know, but yeah, it's just, and that's when I was explaining to Richard about that, So yeah, this is totally different. And then the the stress of all the policies, like 6 feet apart. I don't know if they're doing that in Great Britain, but
Yeah, some
there's
of it.
no way we can do that in the ER or
No,
the hospital.
it's
You know,
impractical.
It's impossible. I
Yeah.
mean, you can't stand 6 feet apart from each other, and we just kind of we ignore. Well, it just doesn't work,
And
and there's
presumably
still,
you've still got those sort of regulations in use now when really
yeah,
nothing's been happening for 6 months or not much.
yeah. I mean, we've had to go. The hospital I know has gone into, you know, isolation mode again in the ICU. They separated the ICU again because there have been patients coming in with those weird conditions again. Not that many, maybe like I think it's like maybe one in an 8-hour shift, maybe two in 24 hours. We're seeing that type of where in over the summer we weren't seeing any, but we are starting to see those again, those weird, no symptoms, no comorbidities, no history, but can't breathe with
Mm.
the what we're calling it, like we're calling it corona pneumonia. We're calling it COVID pneumonia is really what we're calling it. It's a unique type of pneumonia.
So what we're basically saying again then, just to sort of refresh, is that it's a respiratory problem, but it's not typically one that you would appear after the virus has, been doing its, it's not like a respiratory illness caused by a virus. It's a respiratory illness with another cause
Right.
from your experience, which is unknown.
For the most serious cases, I mean,
Yeah, yeah, sure.
like I said,
Some
it's
of it
like
is regular stuff. Yeah,
most people, you just send them home.
yeah.
Even if they test positive, we just send them home and we just give them advice, tell them what to do, drink plenty of fluids, get plenty of rest, don't go to work. So, so it's just these, and that's really my job. I'm to focus on the most serious cases. I don't see any of the ones that are mild or moderate, maybe some of the moderate ones, but so I just see just the serious ones.
Yeah, of
And
course.
so that's the only thing that it's, wow, there's not that many of them, but boy, is it weird. It's new.
Okay,
I can definitely say it's new
okay.
from what
All
we've
right
seen.
then, Steve. So I don't know if there's anything you want to add. I mean, what do you think about, the future of what's going on now with all these, obviously in your own workplace, the regulations and also, I think you've expressed some skepticism of the narrative, the standard narrative where you work and what sort of
Yeah.
reaction you've had to that and stuff.
And I've challenged it. I mean, I've confronted coworkers and stuff. And I say, this is, come on. I mean, you're working here too. You see what's going on. But they carry on as if, I don't understand that. How you could carry on when the evidence is right in front of you. They carry on with the mainstream version of it. And
Mm,
I almost feel like I'm there to kind of bring back reality, to the situation, to a lot of my coworkers. I'm just like, well, that's not what the evidence is showing. When they tell me, oh, you need to get a vaccine, I was like, well, the vaccine, they've tried this before, it doesn't work. It, why would you even want to go there? And they're not making it mandatory at my job. So I respect that. And I should add that I, I respect my employer because they caught something that probably could have paralyzed me for life, and it had to do with vaccine. And it was years ago. It was after we had the swine flu pandemic. They recommended that we all get the swine flu vaccine, and so I went in to get it, and they wouldn't let me get it because of my history. I've had it when I was a child, and I almost died from it. And the said the nurse told me, the employee nurse said, you need to get a letter from your doctor to get the vaccine. And I was
yeah,
like, what? That didn't make any sense to me. So I went to my doctor and I said, I just need a letter, I got to get a vaccine. He goes, well, let me look in your chart and I'll get back to you. But yeah, he's an immunologist, my doctor. And so a couple of days goes by and he calls me and he says, did you get the vaccine? And I go, no. And he goes, good, you're not getting it. I'm going along with your exemption at the hospital. I'm like, well, I work with these patients. I said, I got to get a vaccine. He goes, no. He goes, let me see if I can find one without the swine flu. To this day, he has not found a flu vaccine that doesn't include the swine flu.
Mm.
So all these years, that was back when 2000,
10, probably 2009.
2010. Oh
Yeah,
my gosh, that was 2010.
10 years.
So I've been exempt. They send me a letter every year saying you're exempt from the vaccine because it has a swine flu in it. So that's a bad one for me. I can't get it, you know. So this whole thing where everybody has to get it if you're a hospital worker, yeah, I've not found that to be true. It sounds like they're looking out, at least for now.
I think that, that's just on that point. Obviously, we've got the mainstream putting out various stories, and, same in the UK, slight variations about the mandatory nature of vaccines. And I think that's being used, I think, both by the mainstream and by the alternative media as another scaremongering,
Yeah,
that where if you actually go to the medical people who would be in charge of administering, whatever you think about vaccine safety, and I'm very skeptical of vaccines generally myself from the research I've done, but whatever you think of that, it is again used as another scare tactic, both by the mainstream and by the alternative media, because of some people, it's true, whatever you think, have a toxic reaction to vaccine. Some people have died after being vaccinated, like within hours or a couple of days. It's true, that's all true.
yeah,
So I think, but when you actually get down to it, maybe there isn't such a push towards mandatory vaccination as is being put out both in the mainstream and in the alternative media. So that's a point that we can get people to be, wary of, to check whatever environment they may be working in, check what's actually in their environment, and then,
yeah,
fight your battles on that basis, not on, what you assume might be true, because
exactly.
I'm digressing here slightly, but I had to go to a funeral a couple of weeks ago, and before I went, I was getting really quite upset because I was thinking I was going to have to sit 6 feet apart from my own family, you know,
Yeah,
because I'd seen that on some videos where there were chairs were actually put in the funeral service like 6 feet apart or 3 feet apart, whatever it was, too far apart anyway. But when we actually got to this place, we were all sat next to each other and everyone else was as well. And that particular regulation or rule, whatever it was, had either been relaxed or they weren't following it in that environment. So this is where you've got to check, isn't it? And
yeah,
you've got to make sure you've got the accurate information for where you are, which
right.
may be better or may be worse than other places at the moment. So it's worth checking on that.
Maybe it's
Okay.
just choice, too, if we don't want to do it, no one's gonna like. I know in the county I live in, I think we were one of the first counties where the sheriff, we have a elected office of sheriff. He refused to enforce any of the COVID rules,
Good for him.
and now it's all over the country now. All the sheriffs, all the offices of sheriff, I've heard have all stood up and said they're not going to enforce these rules. These are crazy. You can't enforce them. I mean, they're personal choices, and
Yeah. Yeah. Well, that's good. It's good to hear. We don't have the same system here. We don't have a system of sheriffs. So they've been they've definitely been enforced in some places here in a ridiculous
oh,
way.
really?
Oh
Oh,
yeah, but it's not the same everywhere. I think it depends on the actual local group of police that are dealing with that area to some degree. But yeah, oh yeah, people have been, wrestled to the ground, and for not wearing a mask in some places. It's quite rare that, but it has happened. I've seen the videos.
yeah.
Um,
I
so
haven't seen
yeah,
that either.
good, good.
Yeah. Well, it was great speaking with you.
Well,
You're
thank
a
you. Yeah,
teacher. Yeah, you're definitely one of my teachers. For sure.
well, thank you. No, well, thanks for contacting me and taking the time to sort of lay some of this out there and share some of your experiences, because I think it will be interesting for other people to hear from other health professionals like yourself to get a bit of a different perspective. And again, some people have accused me of saying, oh, you're saying that the illness doesn't exist and all of that. And no, that's not what I'm saying. I think
Right.
from what you've told me, there is an illness which has come about but the cause isn't really known. It doesn't really match with what the mainstream is telling us.
Right.
And the sad thing is that has resulted in people probably unnecessarily dying. And if you'd used a different treatment and not been kind of had this fog of the COVID fog, or whatever you want to call it, put onto you by the media and the authorities, then you might have saved a few lives, mightn't you, from what you've told me? And that's the worst thing, isn't it?
Yes. And that's where I should bring out, this is an excellent article, and that's what gave me the confidence to really want to talk about it more, was this Dr. Jay Bhattacharya.
Okay. Well, maybe then if you could send me any links to such articles, Steve, I'll include those when I post this video, and
Okay.
I'll obviously get your approval before I put this out.
Okay.
Okay. So I'll say thank you very much again for contacting me, and I'll edit this together and maybe put some stills in and things, and anything you want to send me to sort of add into it, I'll try and do that over the next sort of week or so.
Excellent. Yeah, I can do that. Yeah. Thank you, Andrew.
Thank you, Steve. I'll stop the recording there, and we'll maybe speak again soon.
That'd be great. Thank you.
Thank you.